Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. Later in our program, expert answers to your questions about colon cancer. But we begin tonight with an upset for the ages. Never before in NCAA basketball tournament history had a number 16 seed upset a number 1 seed. It happened Friday when UMBC upset Virginia. Zach McCord was there to cover it for the UMBC student newspaper. He joins us live from campus tonight. Zach, thank you for being with us. Talk about the experience, your feelings getting to be in the room, in the arena for that bit of sports history.
Well, I feel like it was just an absolutely surreal experience. It was amazing to watch, especially being a student here at the university and seeing all of my fellow students and the basketball players that I've grown to know celebrate that amazing win was just absolutely unreal.
Talk about the emotions as it went from sort of skepticism, I can't believe what I'm seeing, to as the clock ticks down, you know, this is really happening.
Well, there was a lot of people in the arena who just kind of had a nervous feeling, at least on the UMBC side, as we went into halftime with the 21-21 score. The people that were around me on the press table were very skeptical, waiting for Virginia to go on that run that everybody was hoping for. But as the second half went on, Jairus Lyles, KJ Mora, Arkel Lamar, they all just hit some amazing three-point shots. They were dominating inside the paint, and as the clock started to tick down and Arkel made that dunk towards the end of the game, it started to set in, and with about 2 minutes left, there was tears in the UMBC fan section, and it was just unreal. So many people elated, and such an amazing accomplishment.
When you think about this as a sports fan and a sports writer, how big an upset was this in the range of other sports upsets that we've seen? It's been compared to like USA, USSR hockey.
Well, I definitely believe that it ranks up there with that. Before the other day, nobody knew what UMBC was. Nobody knew what that stood for. Nobody knew where we were from. And we stepped out onto the court on Friday night, and we just made the world fall in love with us.
So that effect lasts beyond the second round game, which of course ended with K-State winning. But even that was, to stay with basketball for a second, that was competitive the whole way through.
Yes, that was definitely an interesting matchup. The game was winnable. We were within 1 point, and neither team scored for about 3 minutes and 31 seconds there towards the end of the game. And there was a lot of anxious feelings in the UMBC fan section where I was right in front of. And we just needed some shots to drop. It wasn't meant to happen. It seemed like that there was a lot of tired legs out on the court after such a long season. And K-State deserves a lot of credit. They played some excellent defense against us. We played excellent defense against them. And in the end, they were just a team that came out on top.
What was it like walking around the arena, walking around Charlotte, wearing UMBC attire once the world knew what UMBC was?
It was definitely very interesting. We had a lot of people that came up to us on the road and were talking to us. I personally had some people approach me when I was wearing my black and gold, my UMBC attire, and they came up, they took pictures with us. When we were on the way back today, actually, through the state of Virginia, North Carolina, and when we got back to Maryland, there was cars that were honking at our bus because we had the Retrievers logo on the side. So we really picked up some fans. The world knows who we are, and it was really interesting experience. We kind of felt like celebrities.
I don't know how much you were able to follow it, but the athletic department social media folks had a pretty good game going Friday too.
Oh yeah, that was definitely very interesting. They had permission to really get out there and interact with the fans and to give people content that they desire. They had a kind of sass to them that really made people laugh and enjoy their Twitter account. And I actually had an opportunity to interact with the guy that was behind the Twitter account, Zach Seidel. And he's a really funny guy, and it just translated to the Twitter account, and all the retweets and stuff made them go viral overnight. They picked up over 100,000 followers in, I believe, 60 hours, which was just amazing to see.
That's pretty incredible. And I mean, this is getting beyond the sports that you cover, but the overall impact where you grow a social media account like that, no doubt there's going to be more students applying to the school ahead. More athletes who are going to want to play, more donors who are going to want to support the university. Pretty amazing that all that comes out of a 40-minute basketball game.
Oh, absolutely. It really transcends what we could have ever imagined. And I think that it's going to translate very well for this athletic department. We got, I think it was about $30 million worth of advertising revenue for free out of those 40 minutes. And our website actually crashed. Our admissions website and our regular website crashed because so many people were clicking on us. So I think that exposure is going to be very valuable to be bringing more students to the University of Maryland, Baltimore County. And I believe that it'll attract more top-notch recruits to come here and compete. We've got a brand new event center. There's a lot of great things happening on campus right now, and I can't wait to see what the future looks like for UMBC as a campus and UMBC athletics.
Well, what does next year look like for the basketball team in terms of conference play?
In terms of conference play, it's going to be very interesting. We're losing our 3 seniors, Jarris Lyles, KJ Mora, and Jordan Grant. The Vermont Catamounts are losing 6 seniors. I believe Albany's losing 4 or 5, and those were really the 3 best teams in our conference. No offense to Hartford, they're a very good team as well, and they're losing some key seniors. So I think that the America East Conference is up for grabs next year, but with having Joe Sherburne, Arkel Lamar come back next year, I believe that we recruited a guard from Temple College who scores 25.8 points per game, and we've got Ricky Council, who's going to be able to play with us next year after redshirting this year. So I think UMBC definitely has a good shot to make a run in the conference next year, and it will be very interesting to watch.
Well, congratulations to Zach McCord for some great sports writing and everybody connected with UMBC. Zach, thank you very much for your time.
Thank you. I appreciate it.
You bet. Just ahead tonight, latest information on colon cancer. We'll be right back.
Got an unused vehicle going nowhere? Donate it to the one place that can take you any place. Visit mpt.org/vehicles and support the programs you love on MPT.
The MPT app puts our programs right at your fingertips, so you can choose when to watch, what to watch, wherever you want to watch it. Download it now.
What happens in Japan and Asia matters to me. With NHK World's newsroom in Tokyo, I get the news live from Japan right at the start of my day.
New ideas come out of Asia all the time. NHK Newsline reports on business, technology, and world events from Tokyo to Bangkok.
Once in the morning gives me a heads up on the competition.
Every hour on the hour, the news I want from Asia.
Watch NHK World now on Comcast Channel 268 and Verizon Channel 480.
Are you turning 70 and a half this year? If so, you generally have to start spending down your retirement account. Even the minimum distribution can place you in a sticky situation. Luckily, you can now use your IRA to make tax-free gifts. Gifts up to $100,000 will never count as income, but always make a difference. That's icing on the cake.
Make your gift for this year before December 31st. Visit mpt.org/support. Joining us in the studio now for our Your Health segment is Dr. Sharif Boutros
Associate Professor of Surgery at the University of Maryland School of Medicine and Medical Director of the Tate Cancer Center, also Chair of Surgical Oncology at the University of Maryland, Baltimore Washington Medical Center. Doctor, thank you for being with us.
Thank you, Jeff. My pleasure.
We're here to focus on colon cancer, and I've seen numbers. It's obviously a leading cause of cancer deaths, and I've seen numbers to indicate that the problem is getting worse, but also some hopeful signs.
Absolutely. I mean, it is unfortunately the second cause of deaths from cancer nationwide. However, in fact, the expectation is getting less and less. And the reason for that we have a very ambitious and enthusiastic plan for screening for colon cancer. One of the good things that we need to discuss is that one of the cancer, or the only one, that we can prevent by screening, not only to detect it at early phase and get the best treatment, but also to prevent it if we screen it early.
Explain how that works. How are you able to basically see the cancer before it's a cancer?
Well, the vast majority of colorectal cancer arise from what's called adenomas or polyp, which is an outgrowth of abnormal cells into the lumen of the colon. And if we can caught that, in fact, early enough before it transforms into a cancer, by removing them, we cure the patient and we prevent it, in fact, to have cancer on the patient.
So we're talking about the large intestine, and these polyps, where do they come from?
Well, like any cancer, in fact, it is unregulated, uncontrolled growth of abnormal cells that arise, in fact, on the colon or the rectum, which are the lower part of our gastrointestinal tract. The colon is about maybe 1.5 meters, about 5 feet in length, and then followed by rectum, about 15 centimeters in length. And this part of our GI tract, the lining of the GI tract of this part of the colon or rectum, they are covered by cells, and these cells, when abnormally grow and get uncontrolled, develop cancer, develop a mass as an outgrowth, as an adenoma, and invade into the wall of the colon. And that's the problem. When it invades into the wall of the colon, it goes, in fact, to deeper layers where the lymphatics and the blood vessels exist and get access, in fact, to spread through lymphatic to lymph nodes or the blood vessels to distant organs.
Who is at risk, and is it a particular age group?
Well, in fact, we believe that most of the cancer for colorectal arise at the mean average age of 68. So if we screen at the age of 50, which are the current recommendation, we can catch, in fact, a very large group of this patient before developing colorectal cancer. And we talked about that we are very enthusiastic, we are very happy about the rate is coming down of deaths from colon cancer. However, the bad information is that, in fact, we are seeing more patients who are young who have colon cancer these days, and they behave, in fact, worse than the average group of patients.
By young, you mean what ages?
Below the age of 50.
And nobody is recommending screening people, for the most part, below 50.
Correct. In fact, if we think about why this developed, why this phenomena developed, why these young people, in fact, now have more cancer than colorectal cancer than before, we have to think about the risk factors. I mean, the risk factors, part of it, you cannot change. You are born with is your genes, your age, cumulative age. However, a good part of it is, in fact, you can change it, modifying your lifestyle. And it's very amazing that just a few minutes ago we are talking about basketball and the athletic field, and in fact that's what we need to do for young population. Most of the young population that have colorectal cancer at young age lack, in fact, physical activity, lack the regular exercise, excessive risk of cancer is contributed to excessive consumption of red meat, processed meat, lack of calcium, lack of vitamin D, excessive smoking, sedentary lifestyle. So as we are seeing these risk factors increasing in our younger population, that explain why we see more young population having colorectal cancer.
Let me remind our viewers, if you have a question about colon cancer, or the screening or treatment recommendations, give us a call. We'll have the number up on the screen. You can also tweet your questions. The Twitter address is @MPT News. Now, when we talk about screening, everybody's heard of colonoscopies. Is that what we're talking about?
Well, colonoscopy is the gold standard. And why that? Because it is, in fact, diagnostic as well as therapeutic at the same time. As you know, Jeff, the colonoscopy is a procedure where mainly a gastroenterologist places a tube when you are under sleep, sedated, to explore the whole colon. That means that he will be able to see the lining of the colon, because you get laxative before the procedure and clean all of the colonic content. And he can, at the same time, remove and discover any gross of abnormal cells and abnormal masses in the colon. So as we said, that the vast majority of colorectal cancer arise from this adenoma, well, the good news is that you have about 10 years from having a small adenoma till it develops cancer. And during this 10 years period, anytime you get a colonoscopy, we can detect it, we can remove it before it turns into cancer. And that's amazing. There is no other cancer who can be prevented by a screening method.
Unfortunately, the screening method is not all that popular for a variety of reasons. What do you think of some of the alternatives that exist?
Well, we always get the first priority to a preventive method, that including the colonoscopy, the sigmoidoscopy. But for patients who, for some reason, cannot do that, we have a test to detect early the cancer process. The idea is that when we have this abnormal growth of cells inside the colon, they start to bleed and they start to shed abnormal cells. And if we are able to detect blood on the stool by immunochemical test, or getting the DNA of the abnormal cell with a DNA test on the stool, we're able to detect cancer at early stage. And that's also is very good, because in fact, the survival for early stage cancer treated is 90 for stage 1, going 80 to stage 2, 63 and less for stage 4.
I was thinking that in doing what you do, surgery frequently for people who are victims of colon cancer, you should be able to make the case to a 50-year-old plus person who's watching who has not had a colonoscopy why they should have it. They've heard the prep is difficult. The idea of it's an invasive procedure doesn't sound too exciting. You have to get knocked out. Why should they do this?
They basically save their lives. As simple as this. It is a only cancer that you can prevent it. You can detect it at precancerous condition. You remove the precancerous phenomena that exist, and you cut the vicious circle to develop a cancer process from it. It is done once every 10 years. It is not very excessive. I know that's inconvenience, but one every 10 years, I think it's very acceptable.
Your typical patient, what were their first symptoms? How did they find out they had colon cancer?
Well, it comes with a variety, in fact, of symptoms, from just weight loss, abdominal pain, constipation, change of the bowel habit, a little bit different in caliber of stool, alternating diarrhea and constipation, but more important, bleeding. And bleeding comes, in fact, in two flavors, basically having a dark stool or bright red blood per stool with the stool. And most importantly, which happens very often, patients who is completely asymptomatic and really doing great have a complete unrelated procedure, hip replacement, coronary artery disease, and has a stent placement, and they start anticoagulate the patient, give him a blood thinner, and that's basically unmask a bleeder on the colon, and start bleeding and start losing weight, and start having a iron deficiency anemia. And that's a red flag. When this happens, in fact, the patient should be thinking about, and the physician should be thinking about colon or rectal cancer that start bleeding.
Let's take a phone call from Shepherdstown. This is Mary. Mary, thank you for calling. Go ahead.
Thank you. I'm curious because I'm in my 70s, and I've been having the screenings regularly since age 50 because my mother had colon cancer in her 70s and passed away from it at 78. So I'm particularly concerned about it. And I do have polyps. They've all been benign. But the doctor said at my age, since they've all been benign, I don't need any more colonoscopies. I'm curious. And he said it's age-related. You know, it's something to do with I would I would not outlive. If I did get cancer, I would probably die before it manifested itself at my age.
But Mary, you're thinking that you could maybe use another one.
Well, I'm wondering, is this customary? You know,
It's a great question. Thank you so much.
Okay.
Well, the definition of geriatric group and the age to stop screening is variable and has been a moving target for the last years. Our population gets older, and they are, in fact, in a very good mental and medical condition. This being the case, I think that's a discussion between the patient and the primary care physician about the expectation, what we will do if there is an abnormal result on the screening, if that's a condition that we are able to address it surgically. Obviously, we don't want to do unnecessary tests when the results of this test will not change the outcome or will not change what we will be able to proceed or as surgery or aggressive method. But if, in fact, the patient is in a good shape and in a good health condition and the life expectation is beyond 10 years, I think that it's very, very reasonable to continue to screen her.
Caller mentioned that her mother had the disease. How often is it hereditary?
Well, it is very often hereditary, but it is not very often a hereditary syndrome, or we cannot pinpoint to a hereditary syndrome. Nevertheless, we know that about 1 every 22 or 24 person will have colon cancer at some point of their life. The important thing is when this occurred to her mom. If it occurred at early age, we think that's more it is a hereditary problem related to genetic disorder, and she can very much, unfortunately, inherit these genes from her mom. If that's not the case, I mean, it's very possible that her mom, like any other person, has increased risk because after the age of 50, you have a cumulative higher risk, and you can be belonging to one of the 20 patients who will have colon
Let's talk
cancer.
about treatment, which is what you do. Surgery is one component. Have the surgical techniques changed at all?
Absolutely. As I would say it in a paradoxical way, we are getting more aggressive with the indication and less aggressive with the approach. We're getting more aggressive with the indication because the stage 4 that was like, oh, it is metastatic colon cancer, did it spread to the liver, or did it spread to the lining of the abdomen, the peritoneal membrane? There is nothing to do. It's not true anymore. In fact, we do a lot of liver resection for the colorectal metastasis, the spread of the cancer to the liver. We do ablation, basically cooking and killing the tumor without resecting it if we cannot resect it for the colorectal liver metastasis. For the lining spread of the abdomen, when there is spread of tumor at the peritoneal membrane, we do a procedure called the cytoreductive surgery and HIPAC. And basically, in a simple way, is take out all of the tumor cells that you can see by your eye and bathe basically the whole abdominal viscera with heated chemotherapy for 90 minutes. And we have fantastic results with that. Patients are cured from spread stage 4 colorectal cancer by doing aggressive approach. At the same time, as I said, paradoxically, we have a minimally invasive approach for that, much more less aggressive surgery by minimally invasive laparoscopic or robotic procedures.
Smaller incision.
Smaller incision. Less pain, early recovery, less blood loss, and early return to function and job.
Phone call from Prince George's County. This is Janet. Janet, thank you for calling. Go ahead.
Hi. My mother died of pancreatic cancer, and I was wondering if this test for colon cancer would diagnose pancreatic cancer, and if not, is there a test for pancreatic cancer?
Great question. Janet, thank you very much.
Well, Janet, it's my passion. I love pancreatic cancer as well and pancreatic surgery. And unfortunately, we don't have a test to detect pancreatic cancer. However, the pancreatic cancer as well comes in basically 2 flavors. One is called the pancreatic ductal adenocarcinoma coming from PANIN, intraepithelial neoplasia, and the other one from a cystic neoplasm. And I highly recommend that you discuss with your primary care physician if there is a chance to get a CAT scan to detect if you have any of the above as a mass effect or a cystic lesion. Based on that, we can discuss what are the risks related to the size, the location, and the content of the cystic lesion, if there is one.
Let's get one more phone call. Cecil County, this is Liz. Liz, thanks for calling. Go ahead.
Hi, I would like to ask the doctor about the possibility of getting the colonoscopy without the anesthesia.
Okay, thank you very much. Now, you don't perform colonoscopies.
Sure, no, I don't, but I know that this is not the first time that I hear this request. Can I do it without anesthesia? So, unfortunately, you will have to have some kind of a sedation. You will be breathing on your own. You will not be intubated. But if you don't like the completely the fact that you will be asleep, there is another method that you can do it less often, less than 10 years, every 5 years, which is the sigmoidoscopy. And that can be done with the less aggressive bowel prep and can be done in a physician office without anesthesia.
Final question for someone who's over 50 and hasn't been screened. Do you need to see a gastroenterologist or primary care? Where do you turn?
I think the best test is the one that is done. And if you need to see somebody, if it is easier for you to have the primary care physician, just go for it. If it is easier, you have access to the gastroenterologist, go for it. Just take a lead on your health.
Very good. Dr. Sharif Boutros, University of Maryland, Baltimore, Washington Medical Center. Doctor, thank you very much.
Thank you.
Thank you for joining us. Coming up Thursday on Your Money and Business, life after the go-to store for toys closes its doors. Join us Thursday at 7 for that. Now, for all of us at MPT, thanks for watching Direct Connection and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.